I struggle with that. I think anybody, we're PTs, right? Like realistically anyone can benefit from us. And in my opinion, if someone is going through an abdominal surgery where they're getting what, like 7 to 9 layers of themselves like cut open, and then we're also giving them a newborn to take care of, how does that person not deserve our care when we're going to go see a 50-year-old's hernia repair that does not have a newborn to take care of? Let alone, what if they have a toddler too? Like, there's just so much that I think people just look at their age and the fact that they can walk around independently, um, and that I don't as an acute care therapist, just because someone can walk independently doesn't mean they don't need us.
Addy Javes, thank you so much for joining me. I have so many questions and I want to hit the ground running. You're a physical therapist with 8 years of experience. You've built programs in both the emergency department for physical therapists to practice there in your hospital and in the obstetrics department for physical therapists to treat patients after cesarean delivery, maybe other types of delivery. And you wrote a paper, you decided your first case report would be on the obstetrics unit. Why?
Well, because I'll be honest, I was doing the CAP OB certification through APTA Pelvic Health, and you had to write a case study. And when I was writing that, I couldn't really find anything out there that was related to a case report or just any kind of article for acute care obstetrics. And then I would say also, like, honestly, one of the reviewers, when I got my CAP OB, had like one of their comments at the end was like, "Hey, have you like considered submitting this to the literature? Because there's nothing out there on it." And I was like, "Oh, no, I haven't, but here we go. Let's try it." So then, I mean, I had to rephrase a lot of it because, there's reformatting and word counts and stuff that all the journals want. But that would be why that happened. I haven't done an ED one.
Wow. So, but why OB? I know that you were doing your first of all, you were doing your CAP OB for people who just don't understand what that is. And then me, who is speaking to an acute care therapist and just realizing how rare is that for an acute care physical therapist to be doing a CAP OB. Have you come across many other acute care PTs doing something in pelvic health or women's health?
No, I mean, I would say when I did the CAPOB labs, there were one of the labs that I did, I was the only acute care therapist in it. And then the other two labs, I think there were maybe two or three acute care therapists in there. So they're out there somewhere, but there's not a lot. I mean, honestly, like I got that because this was like before COVID, my manager got a grant we were trying to get like across the continuum people feeling comfortable with this population. So we were going to get some acute care, some outpatient physical therapists certified so we could kind of like, the ideal goal would have been like, can we see them while they're pregnant? Can we see them in the hospital? Can we see them like postpartum, 6 weeks or whatever postpartum? And then of course, like COVID thwarted that whole plan. But yeah, I think I ended up being the only acute care one that ended up going through with it.
On your whole team.
Yeah, because I think there were only two acute care therapists that were involved at the time. We have a team now. I think there's like at my hospital, there's like four of us that feel strong that we can go onto that floor and do it. But as far as I'm aware, I think I'm the only one that has like a certification.
Amazing. So take us a little bit back with just professional background. Just kind of remind us, how many years, again, have you been in acute care?
8.
8 years. And you have started programs in the emergency department and the obstetrics, and you now grew that program to 4 therapists who are seeing moms on the maternity floor. Is that right?
Hmm.
And from what you and I both did, I did a search after your paper came out just to be sure, right? Because I think I search for it every few months. I'm just like doing another search just in case, because a lot of people will say there's no evidence out there. And then they're like not looking at the right databases. But I have still not come across another case report, at least published in the United States, but anywhere published around the world, that highlights acute care physical therapy after a cesarean delivery or any other type of birth, but specifically like going through what a treatment plan would look like after birth while that patient is still in the hospital. Have you come across anything?
No,
Okay.
that's part of the reason I wrote it too, because I mean, I remember when we were starting our program, I was doing the capo B, but I and they do address acute care a little bit in that, but it doesn't dive very deep. So for me, as someone who I was like, I don't have any pelvic health backgrounds, like I've never been pregnant, like I was very much like, oh no, like how do I know that what I'm doing with someone is okay and what isn't? So I remember that's where I took the enhanced recovery after delivery course that you guys offer, and that was like the most acute care focused thing I could find that actually went over. Oh, this is what you can do with someone, and it's okay.
Yeah.
So I can't find. I still can't find. I mean, I really haven't found anything else. Still, I don't know.
Yeah, no, same. I want to talk about the patient in your case because I still practice in acute care. I would say somewhat. I definitely am not an acute care therapist. I would love to identify as one because I feel like the amount of knowledge you have to have about anyone and everything that walks through the door is just so beyond like what my foundational training was in women's health. The little bit of acute care that I did before I actually started to really practice in the hospital was so sporadic, and it would be on general med surge. I think my first patient was after an abdominal surgery, and so I wasn't really thrown to the wolves when I started treating the cesarean population inpatient. But it definitely didn't feel like it just came easily. Even though I was a women's health therapist, I had practiced with the postpartum population. Being in acute care, it just felt like it was out of my league. And just recently, I treated a patient after shoulder replacement who was walking around and he literally found me, I think, somewhere in the hallway. He's like, "Are you my therapist?" And I was like, "You're just walking around. Okay, we're going to do this." I mean, it was like a 15-minute or less, way less probably, eval. But I was just thinking, reading through your case report, this was a very like, I'm talking about when I think of the most basic foundational, like PT eval of a patient population that you can do, this was everything. This was working with someone who had a high impact score, and I want to talk about what that means. Pretty low pain levels with activity, and just something that just used as, I think, a great case report for students to learn from, for students to just understand what would you be doing in the hospital room, just like what I was doing with that patient after shoulder replacement. Definitely not, even to the extent that you did. You did so much more with this patient after C-section than I did with this patient after shoulder replacement, but it was still entry level. Like that felt entry level. Reading your case report felt like entry level practice. And my question after reading it, I read it twice. And then the second time through is just like, why wouldn't students be taught to treat this population? So I want to go through that if that's okay. But specifically, why did you choose that patient to write about?
I think I chose that one because I don't know. I feel like since there wasn't anything out there on just what to do with a like you said, an entry level patient. This is not a high complexity a case by any means, but I thought that would be the most helpful because if I wrote a case report on someone that was like, like one of those like crazy hemorrhage or something, they get intubated or something like that, that would be very helpful too. However, that would be just a whole different scenario. And I don't think anyone could read that and learn, hey, this is what you would do with someone that's doing pretty good afterwards. So that's why I did the basic one because there wasn't one out there on that. Someone else can do a really complex one if they want to.
That is so true. I was rejected by I think I can say this live, but the Journal of Cardiopulmonary Physical Therapy, because I tried to submit a case report with a patient after an emergency section who was intubated, and then saw PT that we started within 5 days. I mean, I think you started much sooner with this patient, which is the ideal. She was in so much pain, ended up like her IJ line dislodged. There was blood running down her. I mean, yeah, that's the kind of case where it's like, yes, this will scare everyone, and we don't want you to treat on the maternity floor.
Yeah,
Please, no,
yeah.
thank you. Right. And so it was rejected probably for a number of reasons and for good reasons. The first report I would ever want to be published would have been yours. I mean, it was perfect. Addie, it was so easy to read. I loved the treatment plan. And I want to talk about that if we can. But you just described a treatment plan that, again, It was abdominal incision protection. It was taking into account that this person lived on a second story home. You know, she was going into a situation where she'd be discharged right back to her bed, no hospital bed, no bed rails. You wanted to make sure that her vital signs were stable, just walking around. Can you just take us through, like, why specifically, and you even mentioned it in your case report, that obstetric nurses don't take vital signs, but why is that just in basic acute care? Why is that a good practice to take vital signs when a person is doing active physical activity, mobility, things like that?
I mean, I feel like every other unit or just we always take active vitals in acute care because you're just trying to see what your body's response to activity is. Like, how is their like heart handling walking around? Is their blood pressure? Is it dropping? Are they getting like exertional hypotension? Are they orthostatic? Like, I feel like that is a big struggle, I think, from what I've talked to with other people on that unit is active vitals, because in my opinion, no one's gonna go home and just sit down. Like
Right.
they're taking care of their baby, so they're going to be up moving around. They're going to be sitting a lot. They're going to be standing for prolonged periods. They're going to be like lifting their baby. Like they might have to carry their baby up and down a flight of stairs. Like, so when people are just like, why are you taking those active vitals? Like they were fine when they were at rest. And I'm like, well, I think that's the point. Like we're showing that, hey, like maybe they're not handling this very well. And I'm not trying to like throw off a discharge plan or anything. It's just like, oh, hey, maybe if their blood pressure shoots up, that's something to notify the doctor on, and they might change their blood pressure medication dose. That's all we're doing. We're just trying to trying to keep everyone safe here.
Yeah, I'm glad that you're laughing because I think you're also in the same groups as I am, specifically where those questions come up. And I'm like, Addie is mighty quiet, but I think that that is probably the piece I want to like replay, or no, I'll have to like take that from what you just said and use it as the response when an acute care therapist is getting pushback on taking vital signs. And I personally, I've treated in the ICU, ED, other units, orthotrauma, neurofloor, never been questioned as to why am I taking vital signs. I have been questioned. Other therapists have been questioned as to why we do that on the maternity unit. And this patient population experiences, it's not uncommon to experience heavy blood loss. Is that right?
Yeah, I feel like there's the hemorrhage risk, but then you also have to be concerned about like preeclampsia can occur. I think there's a general misconception that you can only get preeclampsia while you're pregnant, but it can actually occur 6 weeks postpartum. So I think taking vitals postpartum is also important to try to catch that.
Right. So tell us a little bit about with this particular patient, you took their vital signs at rest, active. I love the way that the Journal of Acute Care Physical Therapy just, displayed really your intervention, like broke up the different treatments that you chose to do into like their own sections. And I absolutely love that. Abdominal compression. I want to get right into that because we are talking about a patient after cesarean delivery. That comes up a lot. Well, how long do you know to prescribe them an abdominal binder? And as a acute care therapist, you don't have the luxury of following up with people like I would as an outpatient women's health therapist, right? We don't have the luxury, especially if I'm treating in acute care. I'm not going to follow up with that patient. So how do you actually know how to prescribe an abdominal binder for this patient population?
I used recommendations from your course that I took, but I believe you used it from, was it a hernia repair surgery protocol? So
That's
it's like
right. Yeah.
it's literally, this is an abdominal surgery, so we may as well just treat the patient the same way as we would treat another abdominal surgery in the hospital, other than the fact that this patient now also has a newborn child to care for. But that's the guidelines I used. But honestly, I will say too, because even working in acute care my whole career, I feel like all of the stuff that I've learned for C-section, I feel like that's made me be able to like better treat the abdominal surgery patients on our like general surgery unit. Like I'm literally taking those same like exercises, precautions, all that stuff, and just applying it to them.
Yeah, I totally agree. We had to do that for the hernia repair protocol that was published. And it was actually published, and I keep saying 2020, but we actually reached out to the team at Vanderbilt, the lead PT, that was at least the primary author on the protocol for abdominal core surgery, qualitative collaborative. And they've changed their name, but it was basically for hernia repair. And they branched it out to just include all abdominal surgeries. And so I specifically wrote in 2020, because we were lost treating the patient population after C-section, I specifically wrote to the primary author and I said, could this be generalized to C-section population? There's no protocol for these folks. And she said, absolutely, there's no reason. And in the actual full version of the protocol, I mean, this thing is like 32 pages long, but we were printing it out and giving it to patients because we didn't know if they would follow up with anyone. We were almost like, even in your paper, your case report, you even alluded that it was a low likelihood that OBGYNs even referred this patient population to outpatient therapists. So we were giving 32-page hernia repair protocols to C-section moms, but it was in there that they did mention, it was like a little snippet of like lifting precautions, and they showed like a picture of a woman with her baby, and then they did talk about like abdominal wear length, and so that's really what we use to guide our recommendations. You're absolutely right, but I think since I've treated the C-section population, every other abdominal surgery on any other floor, it seems like I've actually fallen more in line with the in-depth education that we give to C-section moms because they're so much more physically active, and then we kind of pare down for the other abdominal surgeries that we see. You're
Yeah,
absolutely right.
I agree.
Yeah. So, okay. So you did resting inactive vital signs, abdominal surgery, incision protection. You specifically talked about like just mobility in and out of bed. So this patient was sitting up in bed when you first came into the room. And we've talked, right? People who understand like a little bit more about the acute care setting also can appreciate this. But for the average person who is like, what's the significance of that? So what? They're sitting up in bed. I did that after my birth. I had a C-section. What's the significance of that? Why was that significant as specifically mentioned in your paper?
I mentioned that because I would assume that most young women that are having babies aren't going home to a bed that lifts up and down or with rails. And they've usually been sitting up. I mean, a lot of moms aren't laying flat like at the end of their pregnancy or sleeping on their back like they're trying to sleep on their side or something, but I feel like they've been upright because laying flat can hurt with just based on where that incision is too. But honestly, like I wanted to make sure they could actually physically get in and out of their own bed at home themselves, just simulate that task. And then also so they know how to one, protect their incision while doing that, two, decrease pain while doing that, and then also not rely on their significant other to help them get in and out of bed every time. Because the one, like, we could obviously, significant other can hurt themselves, mom can hurt themselves. And that's something that I find that, like, not faulting nursing, but that's something that I don't find that they focus on is teaching the mom how to get in and out of a flat bed without a rail. Like, you're just going to use the environment that you have to get in and out of. You're not going to think about, oh, I have to go home and do it in a different way.
Yeah, absolutely. Do you find that just in general, acute care therapists are more likely to simulate that bed at home more than other? Yeah, you're
Yeah,
saying
like,
yes.
that's like our job, right? Is like we're trying to simulate the home environment as best that we can because I would for the majority of acute care patients we're trying to determine discharge disposition, are they safe to go home? So if we can best simulate their home environment, that's help makes it easier for us to be like, yeah, actually you are, or no, this isn't going to work out.
Yeah, that's super, super interesting. I almost kicked myself because I'm like, man, I could have written the first case report, you know? Right, because I mean, just what you described, I'm like, man, that's really how like my best friend, she describes how she was on her bed and she was reaching for something. Like the baby was at the end of the bed and she was maybe whatever, doing something, folding socks, whatever it was, within 2 weeks of her C-section. And she could feel it as soon as she did it. She could feel the incision. And sure enough, it had split open her C-section incision. I mean, then again, weeks of wound care visits to another doctor that she was not expecting, who was not the OBGYN, but they were, caring for her wound. She would send me these photos of just puddles on the floor. I mean, just really just like infected wound care that a new mom did not need, right? Or have the time to go through. And I was just thinking, like, I thought it was so important that you mentioned that in the paper, especially for students, right? Who might want some background on papers. Like, how many times do we get to speak with authors of a paper? Like, why did you do this? Why did you write that? Why did you point that out? And I was just thinking, like, for the most part, I would walk into a hospital room and see moms sitting up in bed. I would not think about their incision until, like, what happened to her made me think of the 3 patients that we did treat that were readmitted to the hospital. And I was like, oh, there's a pattern here. We got to write this down. But it was a commentary, it wasn't a case report. And so you have this published case report of a person that you treated, their pre and post assessments, all of that. And I want to talk a little bit more about like the interventions you chose, because you have one part in there is that when you did lay the bed down flat, you had her raise her arms over her head. Why is that significant?
That I teach them as like a stretch, because I find that a lot of times, but we already talked, the moms are like sitting up in bed when we go in there, but they spend so much of their time sitting, and that can basically compress that incision. So they're in this kind of like crunched position with that incision. And then I basically provide a lot of education on, like scar tissue buildup and stuff. So it's like if you're always sitting in that flexed position, that scar tissue is going to form in that position. And then later, like you're going to be limited, like you're going to have mobility restrictions by like either extension or rotation because the scar tissue's formed there. But I always compare this to like a knee replacement, right? Like if you see someone with a knee replacement, you're getting them to bend their knee, moving it a lot, because if they leave it stuck in one position, scar tissue is going to build up, and then it's going to be hard to get either that like extension back or whatever. So I basically put them in that extended position so that way, one, they can see that, hey, this is safe, this is tolerable, but also to basically tell that scar tissue, hey, don't go there right now. Like, let's not give her a restriction where she's going to maybe need PT later down the road.
Yeah, this is totally fresh because I just treated a patient after knee replacement in the hospital, and we're doing like quad sets, or we're doing things that help extend their knee, because sure enough, I pull back the covers and their knees over a pillow. And so exactly, they're going to heal in that bent position. Same thing in our abdominal tissue, which, I've kind of theorized. I wonder if that's like this pooch that occurs, that just kind of like is becomes solid, but could have been reduced in some way or avoided, the C-section pooch or whatever. And so you did that. You also went over things that just, acute care therapists who are treating and who might be like a little piqued in terms of interest in treating this patient population. You went over really functional activities. There was one section where you were talking about picking up the newborn and making sure that they're setting the newborn down in like a bassinet or that kind of height. So you went over that with this patient as well. Why was that important?
I want to make sure that, well, because they get lifting and precautions after a cesarean section. So I always go over like, okay, it's okay to lift your baby, obviously, but then I want them to be safely doing it. One, for incision protection, but then also just if you think in just like our basic physical therapy mindset, if you are doing repetitive poor body mechanics, you're going to end up with some other impairment later. So I feel like a lot of this education is what I would call proactive, to try to prevent something down the road, instead of, hey, if we don't teach them this, maybe they'll be like bending at their back constantly to pick their baby up and put them down. And then they're going to have a back problem in a few months. Like, because I work in the ER. I see people that come in with that. And then I'm like, oh, hey, maybe it's because you've been putting your baby on the right side of your hip every single time you pick them up. So it's more of like a lot of the education is, hey, how can I help you down the road so like you don't end up with all these problems later on?
Yeah, I mean, 10% what of back pain postpartum is disabling to a point, actually, and that's a gross underestimate. It's actually um higher than that, but it's the 10 I got from the amount of years that some of these individuals are out of work, right? Up to 10 years of disability from postpartum back pain that's been unresolved. And I just don't think that people can appreciate the wellness and the preventative and proactive side of acute care therapy. A lot of us, and even some of my colleagues that I'm starting to work with, I don't know that we think of acute care therapy as proactive and preventative and wellness unless like you are really in it, especially on the outside. You would think that if you're treating someone in the hospital, that's more like tertiary That's more like you waited for that person to get injured, you're treating them in the ED, things like that. Specifically with this population, I think is probably one of the most proactive things that we can do is to take someone like this who's basic, who's functional, in terms of like what we would expect an entry level PT to treat, and then make sure that we're giving them so much information that their risk for readmission to the hospital is that low. For people who are concerned that that's way too much information to give a mom, especially if it's just a day one visit, what's your comment to them?
So I honestly, I was concerned about that too when I first started doing this because I'm not gonna lie, I'm in those rooms for probably anywhere between 40 and 60 minutes. I'm in there for a long time because we don't have
Wow.
OT. We don't have OT. Wish we did. We don't have OT. So I'm addressing a lot, but the way I look at it is that this mom is probably not going to follow up with anyone for like 6 weeks. So, and then even if she does, which she'll probably follow up with her OB, what are the chances that she's going to prioritize herself when she still has like a new baby and then follow up with a PT or someone? Like, I just don't know that everyone is going to prioritize their health to follow up with the right person, especially with especially just with the whole concept that there's back pain postpartum or during pregnancy is like normal, right? Like it's like, well, just because it's something common doesn't necessarily mean that we can't do anything for it or that you have to live with it. But so I would rather give them all the information because I don't actually know what they're going to do next. So at least they have it to read if they forgot everything I told them because they just gave birth 24 hours ago. They at least have like papers to refer to, and then they can be like, yeah, like I remember PT talked to me about that. I can go talk to someone else.
Yeah. And I interviewed moms within, I want to say a 10-month period, all the way up to a 3-year period after they had physical therapy in the hospital after birth. And this was in the same geographical area. They were all exposed to kind of the same, like, protocol, if you will, but the same kind of program that you instituted at your hospital. And their memories were incredibly sharp. Like, I think we decide a lot for people rather than letting them decide for themselves. And so we'll decide, oh, this is too much information, so we're not going to give it. I think that's one of the, it just always felt wrong to me. Yeah, I don't know any other way to say it, but it just feels wrong to decide that this is too much information for a mom. So I'm not going to go over all this stuff. And in this mom's case, I want to kind of like bring this full circle and end with this. Addie, this mom was pushing, had vacuum assisted assistance to try to deliver her baby vaginally. So she had already like had probably some trauma to her pelvic floor, if we could kind of think that in terms of like just what her pelvic floor went through on top of a C-section. So she was not just, a foundational basic patient after a C-section who doesn't need our services. This is not high priority. This is not complicated. This is someone who went through an attempted vaginal delivery, was pushing, had vacuum assisted, that failed, and psychologically is being, taken to the OR, right?
Yeah, I know. I think that is such a difficult part because you add on that whole like traumatic experience to the patient who, because there are obviously elective C-sections, but a lot of them that we see are like, well, I gave it a shot, and then you have some moms that feel guilty that they weren't successful in their vaginal delivery. But then, I mean, honestly, I feel like you said, I find that like this particular patient was so active at baseline. I feel like a lot of the moms who, especially the ones who are active, like so many of them want more information. Like they are all like, oh yeah, like what can I do? Or like, is this okay? Is this not okay? Or like, when can I start doing this again? Like I had some moms talk to me like, when can I start running again? And I'm like, well, it's gonna be a bit. But then I like tell them to go to outpatient therapy, and then sometimes I'll give them that, like, I think the APTA pelvic health like had a whole return to running protocol and be like, this exists. So, but watch out, like try to follow it. But I don't know. I don't want to give people like, I want to give people all the resources they need to be successful because they probably don't know where to look otherwise. Like they're not going to find out that on like TikTok or something.
No, it's true, especially early, like before 6 weeks. It's very hard. It's very hard to find. They're out there. I've met some incredible creators, but they are hard to find when you're looking specifically for your situation. You're active, you're a runner. You want like a guided program, just like we would give someone after an ACL repair, even after a hernia repair. I mean, I keep going back to like these different surgeries we talk about: knee replacement, hip replacement, shoulder replacement. There are people with abdominal surgery who are given rehab like way sooner than a mom would. And just relative speaking, moms are way more active.
It blows my mind. I don't.
Yeah.
I honestly, like, the more I learn about it, the more I'm like, why didn't this take off ages ago? I don't know.
Wow. All right. So you're the author of this incredible paper. I want everyone to be able to find it. And there might be a fee. I say it's worth it. Pay these journals because they're not paying authors. Okay. So support the Journal of Acute Care Physical Therapy. Physical therapy may improve recovery after cesarean section during hospital admission. A case report. Addy Javes, you've been amazing. I want you to end with kind of some advice for the student physical therapist who is like, okay, there's a case report that exists. This wasn't anywhere in the database, and it's not still. You're going to probably find not many case reports, especially in acute care with this patient population, but it's specifically after C-section. For the student physical therapists that are interested in doing something with this patient population, what are some pieces of advice you would give them?
I would tell them to, kind of like we talked about before, treat it like an abdominal surgery. Use your acute care problem solving brain, because that's basically what we have to do the whole time. And then also, honestly, like, there's a ton of social media out there, that, like, all these groups that have a bunch of like PTs and OTs on it, that everyone's pretty responsive. You can ask questions. The other thing would be, if you are getting a rotation in acute care, you can find out if anyone does treat someone on the like maternal unit there. Cause like I take students, and then even if there's a student that's not mine, I still like offer, like, hey, do they want to come shadow me for this, like a C-section or something? Because so then they can observe and see what you actually do there, and then they know it exists. So then if they go get a job somewhere at an acute care hospital, then maybe they can start a program if they don't have one.
Oh, that's awesome. And then for the PTs that are just like, this patient population, it just seems too basic, what would you say to them? Being that you're an ED PT too. I mean, seriously, like to me, ICU, I'm like kind of like watering down your skill set, Addy. You could say so yourself. Like, what areas of the hospital do you treat, first of all? Before you answer that question, where do you treat around the hospital?
Everywhere.
Everywhere. No hesitation, like ICU,
Yeah,
neurotrauma.
I'm primary ED. That's my main spot, but then I do float to any of the units in the hospital.
Would you say the ED is entry level?
I would not. I would not.
Right. Would you say the ICU is entry level?
I also would not say that.
Yeah. Would you say the obstetrics unit is entry level?
I think it could be, yes, for
So,
I think there's always the classic "it depends" physical therapy answer. But I think for a C-section, yes, I think an entry-level therapist could do this. Like, that's great. If there's always going to be a more complex, weird scenario, but that always happens in acute care. So if you're
always. Yeah.
always, like, you're never just
I
going
would
to.
agree with you. I would absolutely agree with you. I would say that what scared me the most being in acute care on the maternity unit was high risk pregnancy, hands down.
Yes, that's what
And then
scares
your your
everyone.
your postpartum hemorrhage, and just the crazy, like, had to go to the ICU, now they're back, or they had a hysterectomy at the time of birth, and there's just so much grief and trauma around there. Perinatal loss, like the things that I've seen in acute care on the maternity unit, I would say yes. The occasional like non-entry level case you could find anywhere, right? But general obstetrics, I would absolutely say yes, entry level. So for the entry level PTs or the licensed many years out PTs that are like, I don't have experience with that. I don't have any interest, or maybe they're not a priority. What would be your final thoughts to them?
For the ones that don't have interest, or the ones that don't think it's a priority.
Are they a separate group? I don't know. I mean,
I guess maybe that's a similar group. I struggle with that. I think anybody, we're PTs, right? Like, realistically, anyone can benefit from us. And in my opinion, if someone is going through an abdominal surgery where they're getting what, like 7 to 9 layers of themselves like cut open, and then we're also giving them a newborn to take care of. How does that person not deserve our care when we're going to go see a 50-year-old's hernia repair that does not have a newborn to take care of? Let alone, what if they have a toddler too? Like there's just so much that I think people just look at their age and the fact that they can walk around independently, and that I don't as an acute care therapist, just because someone can walk independently doesn't mean they don't need us. Put me
Nice.
on a big soapbox there. I just
I
wanted
know.
to.
I got the fire out, Addie. This has been amazing. I cannot thank you for your time enough. Addy Javes, author of Physical Therapy May Improve Recovery After Cesarean Section During Hospital Admission. This case report is fire,
Oh,
by
thanks.
the way. It really is. I mean, honestly, I read through it twice and I'm just so pumped to really tell people about it and to have you on. Thank you.
Yeah, thanks for having me. It was fun.